There we go. Please do use the Q&A function here in Zoom. The whole purpose of today is not just for some experts to present and for people to listen. It's actually about our three experts today presenting to catalyze a discussion, and that is all about you as attendees getting involved as well. So we've got a Q&A function. Just fire stuff into there as it hits you. And I'll be keeping a close eye on that as chair for today. I will then be fielding those questions to our panelists once we get into the Q&A. So turning to the panelists, big thank you to the three we have here today. We've got Steve Taylor, who is a program manager in the drug and alcohol team in the Office of Health Improvement and Disparities, I think I got that right, which is nestled within the Department of Health and Social Care. We've got Dr. Roya Vizari, who is the Medical Director of Humankind, and I think is a GP by training, although, yeah, she's nodding, good. We've got Dr. Jeffrey Failer, who is a consultant psychiatrist at Central and North West London NHS Foundation Trust. So I'm really pleased to have both NHS and voluntary sector provision perspectives here today. So once again, thank you for being part of it. I don't think the relevance of this as a topic needs restating when we've had just a couple of weeks ago the latest statistics of drug-related deaths and some really shocking patterns emerging from that, which involve benzodiazepine use and particularly kind of polydrug use, benzos and opiates. And I know we're going to be talking about that today. On the policy front, we've obviously had the Black Review, we've had the drug strategy, we've had the funding, and it's kind of flowing into our fragmented system that's been starved of resource for a decade. So it's a fantastic opportunity to have this funding. We are at a moment of gradual transformation, I think. And we've got to seize upon the kind of green shoots and amplify them and share the good practice. And I honestly think on the good practice front, the issue of benzos has got to be up there as one of the chief issues kind of facing our field and the people we serve and how we reduce the harm that people are experiencing. And just lastly, before I turn over to Steve, we're here not to say we've had some conversations and we've got this issue sorted and here's what we've all got to do. We're here to say we've had some conversations. This topic's really complex. There's so much stuff going on, and it comes down to people's life circumstances, the poverty people experience, the health inequalities, the myriad of other things that are going on in people's lives, as well as the drug and or alcohol use. It's as much about that as all the clinical stuff. So we're here to actually say this is complex and we don't have all the answers, but what we do have is a commitment to talk about these issues, to explore them, to try and bottom them out, to try and help each other to improve the overall system response. And I can't think of a better way to start that, actually, to have a national conversation, to have a webinar. So we're here to kind of talk, but also to listen, really. And I hope this can catalyze activity for you and your organizations, and let's keep the conversation going. Great. Okay, that's enough from me. So I'm going to turn to Steve as our first presenter. So Steve, over to you.
Thank you, Oliver. I think I've got that sharing now.
Yeah, that looks good.
Great. I want to see that one. So yeah, thank you, Oliver. Good afternoon, everyone. It's very good to be here, and I'm grateful to Collective Voice for organising this. I'm going to do some kind of more high-level scene setting before you get into some more real-world, if you like, examples. So my first slide is just showing benzodiazepines in drug poisoning deaths over the past 16 years in England and Wales. So being much bigger, England, you can see, clearly drives the total, but I've separated it out just to show the slight difference that Wales brings. What you should always note about ONS data is that these are deaths by year of registration, not when the deaths actually occurred. And there are some significant delays in registering deaths, and some of those got worse during the pandemic. So it may be that we're going to keep seeing some of the previous year's deaths appearing in subsequent years' statistics. Now, if this works, yes, it does. So here at the bottom, I just added the deaths involving only benzodiazepines and no other drugs. And it shows what most of you will probably already know very well, that benzos alone rarely result in death. It's only generally when they're combined with other drugs, and particularly with respiratory suppressants. So opioids, alcohol, pregabalin. And then the ONS, all, the reason I put it in inverted commas, all benzos category, only covers the sort of traditional and medicinal benzodiazepines. So what I've done here on the orange line is added the benzo analogues that are reported by ONS as new psychoactive substances. So I'm just going to mute for a second and cough. That should be better. You'll see that they're much, much smaller in number, the benzo analogues, but they've been rising very rapidly in recent years and went up just about 178%. I think it is, between 2020 and 2021, and that absolutely fits with what we're hearing, increasing reports of people moving from using diverted prescription medicines to the increasingly available what are called street benzos. So illicitly produced benzodiazepine analogues like atizanam, bromazepam, and a whole host of others. So in 2020, OHID issued a national alert about some of these street benzodiazepines and the proliferation that we are seeing of them. So where you used to only really have UK diverted medicines, now you see a whole lot of imports of medicines coming in from other countries. You see a lot of illegitimate clones of those, so they still contain the medicines that they claim to, but they're obviously counterfeit. You can often tell from the packaging. But also a lot of just completely faked medicines. So they often look loosely like a genuine medicine, and then but increasingly they contain one of these kind of nastier benzo analogues. So there's a lot of blue supposed diazepam tablets out there with markings that mirror some of those of the legitimate medicines, but they don't contain diazepam. And Xanax bars. There's a whole host of different colours, shapes, sizes of Xanax bars out there, some of which contain alprazolam and an increasing number of which don't, and then just a whole host more. So then what I just want to look at people in treatment in England for benzos. It's been falling off for quite a long time, but it started to rise around the same time as the deaths really started to increase. I'm just going to try and, that might be hard to see, but I've just put the deaths graph in underneath it. So you can see the relationship between when the deaths really took off in about 2018-19 is also when the NPS really took off, and when people started to come back to treatment, reporting these. So that's the current state of play with deaths and treatment. I just want to talk a bit about what the national clinical guidelines say about treating benzodiazepine. They say it's more likely to happen in secondary care, where you can provide some kind of specialist input, and it would generally be provided only as a short-term, time-limited detoxification. There's not a lot of good evidence that long-term substitute prescribing reduces harm. And there is evidence that long-term prescribing does cause harm. So generally what the guidelines say is to continue a current benzodiazepines prescription if someone's been on it but can convert them, or if someone's coming over from street benzos, you would also generally try to convert the dose to a broadly equivalent dose of diazepam, but with a ceiling usually around 30 milligrams of diazepam. You can go higher than that, but generally nothing more than 50 is necessary to prevent withdrawals and seizures. So I'm just juggling too many windows here. I just want to talk briefly about why maintenance stopped. So the guidelines advised against long-term maintenance prescribing, partly because there was extensive overuse of the medicines. I think it had just become normalized to provide benzos alongside OST in particular. But also you've got some issues whereby tolerance is developing to the therapeutic dosing that you provide. So maintenance actually becomes an increasing dose. And then there are other potential side effects of long-term prescribing of benzos. There's a reported long-term memory and other cognitive issues. There have also been some reports of paradoxical violence with them. So it's not like prescribing them long-term is without risks. But then the thing to do is to balance the benefits and the risks. So the guidelines are really clear that that's what they are. They're guidelines, not trend lines, and you would expect clinical practice and patients to step outside guidelines in about 20% of cases, roughly. So longer term prescribing may be necessary for some people in some circumstances. And it may be that the prevalence and high use of street benzos that we talked about a minute ago is one of those circumstances in which clinicians then become more likely to prescribe long term. However, it should always be an individual risk-benefit assessment. And I think I hope we'd all agree that the recovery movement of the last decade and more is something that should apply for everyone, regardless of what they're in treatment for. And you long term, you ideally wouldn't want to be keeping people on these medicines if they do stand a chance of coming off them. Just in terms of what OHID's doing around this, in addition to being here today, we commissioned an evidence review from PHE's library service a while ago, but it found remarkably little good evidence for providing maintenance prescribing. So what we definitely need is more research, and we're looking at proposing a randomized controlled trial study on maintenance to the National Institute for Health Research. We're then looking at the guidance, and particularly the Orange Book and the NICE guidance, and wondering about the need to update that based on the existing problems and as that research evidence starts to come through. But I think that does depend on finding the evidence. And then finally, I just wanted to talk about the opportunities that arise from the drug strategy. So there's a lot of new money, obviously, and that is intended to increase the capacity and the competence of treatment services, and with that, their ability to treat more people for a wider range of drug problems. So you would hope to have more people able to come into treatment for non-opioid problems as treatment capacity expands, and for them to then receive better treatment as the competence of the workforce improves as well. I think that's me.
Fantastic. Thank you, Steve. Perfect timekeeping as well. So that's great. Thank you. When I'm sure we'll be coming back to a lot of these issues once we get into our Q&A. I can see a couple of people have put questions in, so keep them flowing, folks, and we'll have lots to work with. Great. We are now going over to Roya for her presentation. Roya.
I'll unmute myself. Hopefully you can see me. And can you see the slides now? Brilliant. Thank you. I will hopefully keep to time, but Steve is a pro at that compared to myself. So for those of you who may not know me, I'm Roya. I've worked for the last 25 years in a variety of roles, seen and been responsible for prescribing benzodiazepines from accident and emergency to surgical specialties, and really finally mostly as a GP, and specifically working within drug and alcohol services for the last 15 years. So just based on my personal experience and practice, I'd just share just my first slide, which is just some of the key messages that I've learned. And I'm going to see whether that comes up. Next slides come up for you guys. Brilliant, thank you. So each person's experience is very much different. So withdrawal symptoms can vary quite significantly. And there's no standardized reduction or detox regime like we have possibly for other substances like alcohol, where we might have a 7 or 10-day fixed regime. Withdrawal symptoms may be hard to predict and manage. And that's one of the first areas I thought I could share. Increasing polysubstance use. So Steve's presentation has really highlighted the concern there around the toxic interactions of benzos and other substances. And I might use the word benzos just to keep the flow going. But when I say benzos, I mean the general class of benzodiazepines. And in my opinion, harm reduction approach really does save lives. The third point is around the importance of that strong therapeutic alliance and that ability to make shared decisions. Community benzodiazepine withdrawal is possible. We still definitely need inpatient solutions though for some. And finally, people who use benzodiazepines or those people who have stopped using benzodiazepines need to be visible and listened to. And it's invaluable, I found, to be curious and learn from those people who have used benzodiazepines and have stopped. So I could just stop there with that final slide. But with permission, I just want to run through some of the things that are interesting around the pharmacology of benzos that I think Steve's already touched upon. I have a couple of slides of what we do within humankind, which I suspect is not going to be very much different to what Jeffrey does within his services. An example of a service dealing with maintenance benzo prescribing. And then finally, maybe some questions or things that we might want to explore in today's webinar. So cracking on to keep to time. Benzos. Now, I suspect many of you will already know what's on these next two slides, so I'll make it a quick run through. Benzodiazepines, they're grouped together. They've got a similar chemical structure, mechanism of action. That's how they work. And sometimes another group of drug called Z drugs, zopiclone is one of them, is grouped together because they also have a similar type of action of benzos. So they act on the central nervous system. If you want to know the detail, they act on a particular receptor, GABA receptor, and I know some of you will know there's a subtype A that they react with. And when that happens, when benzodiazepines bind with that receptor, you get a sort of calming effect. It reduces the excitability of the nervous system, slows things down. So depending on where and what part of the nervous system is being affected, you could get a variety of functions and effects of the benzos. And each benzo has a different pattern of effect. So, for example, temazepam is more of a sedative. Diazepam is more of an anxiolytic. It really is great at relieving the psychological symptoms of anxiety. Chlordiazepoxide we use often to prevent seizures, and the list goes on. So there's a range of different effects and a range of different durations of actions if you take a look. Some benzodiazepines last for an hour, possibly, in the system. Some can last for days. The body gets rid of benzodiazepines in the liver, broken down, and some benzos are really quite interesting because when they're broken down, they're also broken down into some active metabolites, as we call them. So again, showing the variation there. Potency. There's lots of tables out there comparing, for example, a dose of diazepam compared to some other benzodiazepines, and you are wary when you use them. I think there's a great variability in people depending on their liver function, kidney function, age, depending on the dose and way of taking benzodiazepines. It's useful to have reference to those tables, but need to be interpreted. I like Steve's, they're not tram lines, they're guidelines, those tables. Steve also mentioned the word tolerance. Now, again, I appreciate as an experienced audience, you may already know this term, but it's really important to understand that when you take, what that is how your body changes to that same initial dose over time. Maybe simply put, the body sort of resets, so that same amount initial dose taken, maybe over a matter of weeks, then has a little effect. You need a higher dose for it to work, and then that higher dose over time needs to go even higher to have the same effect. And that's the principle of tolerance, and that definitely happens with benzodiazepines, as Steve's mentioned, and I'm sure Jeff will as well. With respect to withdrawal and dependence, I'll come back to that on that second slide. And maybe just to pause on toxicity. We know that there are dangers of using benzodiazepines in their own self, but there are significant interactions with other, what we term CNS depressants, such as opioids or alcohol. And to maybe labor that point, that an individual might normally be able to take this amount of benzos on their own, or this amount of alcohol on their own, or this amount of opiates on its own. But together or in combination, knowingly or unknowingly, the potential effect can be, as we can see with the figures, can be quite catastrophic, and we have to be aware of that polysubstance use. Moving on, so once you sort of know what effects benzos can have, then the list of what they might be prescribed for or used for sort of makes sense. Important just to acknowledge that for some people, using benzodiazepines helps get a better effect from other drugs or substances, or reduce the effect or withdrawal from other drugs or substances. And I think Steve sort of mentioned that the violence, I mean, there is a paradoxical, you can get a stimulant effect with benzos, you can get depression, emotional blunting. These are just a selection of dependence and withdrawal symptoms I've picked out. And it sort of can illustrate how challenging it can be to withdraw off benzos. Each person is quite unique, and the type of benzos, the quality, the dose, how you take it, your psychosocial circumstances all affect the effects a benzo has, and possibly coming off it as well. Okay. Moving on to the humankind approach, which again may be quite similar to the people who are on the call. Immediate risks of harm, overdose, harm reduction, very important. And I personally advocate that if you come across an overdose situation, even if you think the primary substance is benzodiazepine, give naloxone. We know naloxone doesn't reverse benzodiazepine, but as we've talked about, if you've got a little bit of opiates sitting there along with the benzos, it could be life-saving. I really strongly encourage our teams to be curious and explore. And I know I've had to sometimes challenge myself to ask more open questions about why is that use of benzodiazepine happening, and understand a little bit more of that pattern of use so that you can make an important shared decision, and recognize the fear and stigma that can exist in the practitioner themselves when you're not too sure what else you could offer, but also to the individual when they are sharing those risks or behaviours with you. Moving on to what I would call the routine comprehensive risk assessment. Again, use strength-based language, build on the resilience that you have in front of you with a person. Shared risk assessments, things that as a clinician you might do or not do, how does that affect the outcome? And then the usual interventions that I've just listed: psychosocial, psychological, very specific psychological interventions, and also looking at prescribed medication that I'll come to on my next slide. So the guidance that we refer to, that Steve summarised, you've got the orange book. You've got there's a CKS summary that was updated in April 22. And again, we'll make sure there's links at the end of the webinar that you've got to these. There's the Ashton Manual, and that's a really quite impressive body of work. For me, it showed a real in-depth understanding of the use of benzodiazepines in the community, and a real empathy for the individual, and some solutions of how you could support somebody to make changes. We also have got the withdrawal tool. So our guidance, there are multiple substances in it. On the benzos, we've got 12 points, and they, I think, again, Steve did highlight, and I don't wish to sort of repeat a lot of it, but I will just go through the fact that there's no evidence for long-term maintenance prescribing, long-term use of diazepam over 30 milligrams. We know that it can cause dependence, tolerance, effects on how you think and how you move, and the risks associated with that. And there are regimes that we've got in our guidance around how to reduce gradually, how to maybe convert to one benzodiazepine, to do that in a stepwise format, and to really use information to make shared decision making with the person. We've also got a prescribing formulary of drugs that we can prescribe within our services, and we sort of monitor that using prescribing reports and a governance structure, because as we heard, when you go outside of guidance, it's important to do that in a thought through way, and that's something that I know we've worked through by having our prescribing formulary and a way of signing off, in a way, going outside of guidance there. Harm reduction information, really important. We've got some benzodiazepine leaflets, and I've seen some great ones out there as well. But that's really that's part of our toolkit, let's say, that we use in our interactions with people that are using benzodiazepines. So with permission, I've got 2 slides. This is early, very simple data from a service that we took on responsibility for in the middle of the pandemic. So what we found in this service, this is a service that's got lots of hubs, a wide geography. And interestingly, in one particular hub, we found that there was a great deal of people on inherited benzodiazepine prescribing versus the other hubs. There were 25 people. You've got some demographics summarized there. And there were also individuals that were prescribed OST, opiate substitute therapy. Some were on methadone, some were on buprenorphine. The pie chart just explains the primary substance of those individuals. And for the keen eye on you, and there'll be some great data people there, when I talk about the number of people being on diazepam, you'll work out that one person was only on nitrazepam. There was 5 on both diazepam and nitrazepam, and the rest on diazepam, and there were the doses that those individuals were on. And this was around the time where there was a concerted effort to think about maintenance benzo prescribing and what we could do about it. So work began in very difficult circumstances. So we will all remember the challenges we're dealing with in 2020 with COVID, both as individuals coming to our services and also our workforce. And I just want to let you know, well, how did it go when we did a 2-year snapshot of the same cohort? Well, just over half, there was no change to the benzodiazepine. And the same amount of people who stopped was the same number of people who made a slight reduction. And you can see, if you can take a look at the milligrams, there's not a lot of difference there for what we might describe as a reduction in those doses. And this was on the background of having very little face-to-face and not having the plethora of interventions that we would like to offer due to the pandemic, such as the intensive psychological or psychosocial interventions. But I think for me, it summarizes what I've experienced over the number of years of what a challenge it is to make changes to benzodiazepine. And this is, as I said, it's early. We're hoping to write things up as a case study. But I wanted to share this just today, just to encourage anybody else on the call that had their own little insights, groups or approaches to bring forward, and we can discuss that as well. What we took away from the early reflections really within this service of culture and practice, there was, as I said, lots of different hubs. It was only one particular hub where this was happening. And there was an appreciation of the expectation of either the practitioner or that community with respect to benzodiazepine maintenance prescribing. We noted that there were some key individuals who really supported and were passionate about making changes to benzos and were quite experienced compared to others. And that was a trend we saw with changes with the people who'd managed to make some changes over that 2 years of who they were working with. And just recognition, there's much more data to be mined here. And this is just a first little glance just to share with you in its raw state to generate some discussion. Thank you. So additional learning. This was the first slide I put up. And I think when we've reflected a bit more, we've really understood that time is so precious in this complex. To manage this complex problem, we need greater time in consultations with clinicians. We need increased contact with key workers, lower caseloads, and to really work on building up the therapeutic alliance and to be curious. And more research into different cohorts of people. What is the best approach to manage, for example, individuals that are prescribed OST or using benzodiazepines in a different way? We also recognize the real need to explore more about polysubstance use. So can we get better identifying types of benzos out there that might support our clinical decision making? And can we upskill the workforce specifically around benzos and polysubstance use? And finally, so these are just some ideas, possible things to consider. It might be that you want to explore these further on today on this webinar or not. And it's about recognizing, again, specific training needs for benzos and polysubstance use, and whether we need some specialist interventions we want to develop for this cohort, whether it's PSI work or group work. To build on the continued sort of partnership working we've got with our local and national intelligence network, for example, amnesty boxes and drug checking, to really understand what's happening in our local communities. Reversal medication. Now, I've used flumazenil many years ago when I worked in hospital, many years ago. And it's a question out there, would a different formulation of, and is there an evidence base to think about using that in the community to reverse benzo overdose? Question. And a really personal passion of mine, it's around, it's lived experience. It's really recognizing people who've used benzodiazepines or have stopped using them. And I know if I want to make a change, seeing others for me is greatly motivating and supportive. And I maybe would like to say that actually even using colleagues outside of health and social care, film and the arts, they've got real skill in capturing stories in the narrative. Maybe that's something else that we can look to explore. So I'll end on that. Thank you for your time and look forward to hearing Jeffrey's insights now. Thank you.
Thank you, Roya. Really comprehensive overview there of the kind of clinical practice, but also the, I found really fascinating all the actual neuro pharmacology, if that's the right word, of how these drugs actually affect people on a kind of physical level. And then rounding off, I like the personal reflections at the end as well. Great. Okay. Jeffrey, could we hand over to you, please?
Oh, I'm sorry, I'm struggling to unmute myself, but I think I've got it there. And I'm assuming you can see my screen. Thanks so much. I knew there was going to be a technical difficulty somewhere along the way. Hopefully that's the last one for me. So I'm Jeffrey Feller. I'm a consultant psychiatrist in addictions, and I'm clinical director in CNWL's Addictions Directorate. And the good thing about going last is that everyone's covered all the theory. So it just allows me to talk, because I could talk for a very long time on this, but I've only got 10 minutes. So I will resist doing that and leave time for questions, because I can see there are a lot of those already. So as you've gathered, why are we here discussing this? And that's because we just don't have the answers. Let's face it, such varying attitudes to how our addiction services address benzo use and misuse. Some opt to address this, some deliberately opt not to, and in a way turn a blind eye because this is such a vexed, complex, contentious issue. We know that benzos as sedatives are liked by many of our clients because they work well. That's never debated. We know they work. People will keep stressing that, and that's never under discussion. It's the addictive potential, and we know that many of our clients will much more readily address their heroin use than their benzo use. Now, this is really telling. So yes, it substantiates the effects of opiates, alcohol, other sedatives. It is a substance that's easily cross-substituting other sedative addictions. So one may address the alcohol problem only to go on to using benzos. We know that benzos have historically been prescribed quite readily. And let's be honest, compared to the medications that they followed, in the 60s and 70s, before all of our times, chloral hydrate, barbiturates, these are relatively safe substances. Of course, what I'm going to say now This is all relative and compared to what we had before, because the other issue here is, as Steve highlighted, deaths are increasing. So benzo-related deaths, and you saw the graph, and the figures are stark. The hot of the press data for 2021 shows a rise of 13% compared to 2020. But then 2020 showed a 19% rise compared to 2019. So these are deaths relating to benzodiazepines and their analogs. And I think it's important to mention the analogs, because I know many of you are encountering them in clinical practice. These are the novel benzos, if you like. So grappling with this, how we manage this and our attitudes towards this, and at times our patients' reluctance to address this, I conducted a scoping exercise in our organization, looking at 5 services. All of them are London-based. And all we did is we just brought our clinicians, prescribers, primarily managers, around the table and said, tell us about your views on benzo use, but also your attitudes towards prescribing. So I have to say, though, when we did this in 2021, we were reflecting on data during the COVID pandemic. And I realize now that that is really clouding the picture, because we found then that actually there was no increase in benzo-related presentations. But I realize now that that's really related to COVID, then related to the scale of the problem. Because when I look at very recent data, I'm seeing that it is increasing beyond pre-pandemic levels, particularly in some services. So the theme of variation, mixed picture, comes up a lot. And I have to say that in my own service in Hillingdon and West London, the figures are quite staggering in terms of how much benzo-related pathology we are seeing. But then it's worth bearing in mind that we are one of the services that do prescribe for benzo dependence. So decrease during the pandemic, fine, we'll just put that aside. Broad consensus, but again, not everyone agrees that illicit benzo use is more prevalent than is being recorded. And I guess my question then was, well, if it's not being recorded, then where, how are we knowing about this? And also views, the commonest view was that some of our clients, or most of our clients, are underreporting their benzo use, but then there were some reports that they were over-reporting as well. So the mixed picture really predominates here. But I just have to say that diazepam remained the illicit benzodiazepine of choice. So certainly in central West London, we're not seeing these analogs. It doesn't mean they don't exist. It just means that patients are coming in as large numbers. And of course, as has already been mentioned, alprazolam Xanax use is increasing. And certainly we are finding that. So this doesn't give the answers. It unpicks it, and it actually raises more questions. And just continuing from that, that's the scale of the picture, as we can discover by having discussions. But then what about the attitudes towards prescribing? Because we know that really differs, even in our own organization. Again, variations, but a number of factors were cited in terms of influencing prescribing policy. The lead clinician is obviously key in this. There's also what was often quoted was commissioning policy. I suspect somewhat unfairly. I'm sure there's commissioners with us today, and I think that commissioners will probably say that you commission to provide a service to manage addictions. You wouldn't be that specific about, oh no, you don't treat benzo dependence. That's not a substance we're commissioning you to provide. So I think some of these really need to be addressed. And then also our role in partnership as well has come up. And, are we lead provider? What are the attitudes of some of our partners? And I think the reality is that this is just a very difficult area to address, not least because we don't have a lot of research in this area. Compared to OST, it pales in comparison amongst this patient group of dependent patients. We're not talking about those with anxiety and insomnia. we're talking about those with dependence. There is a dearth of research. And of course, that what stands to reason, you won't be surprised, the options. So in other words, how people manage this. Well, there were different ways. The first one was just to not deal with it and refer back to the GP, ideally with some advice, I would hope, certainly, about how to address this. But then some GPs don't feel able to address this because often these patients present with significant comorbidity and complexity. Some would prescribe in specific scenarios, as in complexity. So where the GP says, look, it's too complex for me to manage, please take this over. And then some are prescribing for all dependence, primary and secondary. I think it's probably a good time to leave that now and to think about guidance, because I know that's what you want to know. You know there's a mixed picture, you know it's difficult, and this is in my view, as I understand typical guidelines. So of course we'd opt for lowest dose possible, shortest time frame possible, and we don't want dependence to evolve, and you've got about 4 weeks. And normally good practice is to reduce. I mean, it doesn't have to be that gradually if somebody's been on it only for a week or two, but normally you would titrate down, even if you don't feel there is dependence, if you can. And that is the biggest difficulty, is often once you start this medication, it is very difficult to get patients off it. And of course, only one benzo, and I think services and GPs are far less likely nowadays to prescribe dual benzos. Temazepam was a big problem when I started in my consultant job 20 years ago, less so now, one benzo, and that would be diazepam, certainly when we prescribe it for dependence, and that is what we are prescribing it for. Range, not too difficult. Steve already alluded to the maximums, and the BNF does allow diazepam being prescribed up to 40 milligrams. And I know that the GPs amongst us will be quite surprised that it's that high, thinking, my gosh, that's a really high dose. But for us, that's quite standard practice. And diazepam is what we would use to manage dependence. But, thinking outside addiction setting, because of course we want to prevent these patients coming to us in the first place. It's about acute self-limiting situations that we would only advocate their use. And acute does mean acute. I'm thinking here of acute psychotic disorder, acute depression. Again, I always say be really careful, because often, as we know, depression is chronic, long-standing, dysthymia. Really an acute crisis, or is there a pattern of crises? The patient will like this medication, that's not debated. Severe symptoms, of course, never for mild symptoms. Acute pain, acute back pain. Again, be careful, because back pain is often very chronic. So acute is really the operative word here. And I know that it is really difficult, particularly in primary care when time is limited. Patients can often be very demanding of benzo prescribing. But the thing is that once they're on benzos, it's very difficult to stop them because they work so well. And I think if somebody has a history of addiction, certainly one would struggle to make a case for prescribing benzos or even Z drugs. Because it often just continues. But I do feel it is our business. I always have felt that. And, when an addiction develops, addiction services should address this holistically, because turning a blind eye, I don't think helps anyone, to cherry pick addressing the opiates or the alcohol and leaving the benzos out there. And perhaps the person is getting, a whole. And I know that that has helped locally. In fact, it's helped so much that I know some of my local GPs don't prescribe benzos. And I've said, well, I didn't really say that, but they're saying, look, we just don't want to go there. We don't want to get involved in this. And our policy in practice now is we don't do this. And I'm saying, well, fine, if that's your policy, I'm happy to be blamed as well if you want to use me and blame me for that protocol. Uniformity in approach, well, that's a difficult one, because as you can see, we're struggling with that even within organizations. Attitude change to own this, because I think there's a tendency to deny that this is our problem, that it's something we need to own. And I think I will stop there for fear of going over.
Thank you,
Let's stop
Jeffrey.
here.
Yeah, thank you. No, that's a brilliant kind of personal snapshot of where where you're at and where your organization is at in rising to this challenge, really, in a nice mix of kind of professional and clinical stuff, and then, like I say, the more personal reflections as well. So thank you. Okay, that is brilliant. So we've had our three speakers. We have got quite a lot of questions in the Q&A function, but please do keep these flowing in. We've got a decent amount of time. We've got sort of about 35 minutes to get into the Q&A, which is great. What I'm going to try to do is not precise science, but I'm going to try to start with some of the kind of shorter knowledge-based questions and come to specific people. We'll run through a few of those and then maybe get into some of the more kind of complex stuff, which is more of a discussion, and there'll probably be more of you kind of coming in. So if that's okay. So Steve, I'm going to come to you with the first question. So Lily has asked, what are the common adulterants in the fake Xanax bars? Have there been any instances in the UK where these have been laced with opioid substances?
Okay, so there's a number of different answers to this. One is that an awful lot of them never get tested, so we don't really know what's in them. Where they have been tested, I would say there's been a bit of a shift over the last few years. So a lot of them were alprazolam. They might not have been genuine Xanax, but they were alprazolam to start with. But increasingly, you don't see alprazolam in there. You'd see clonazepam, flualprazolam, flubromazolam, etizolam. You know, it's just an alphabetic spaghetti of benzo and benzo analog names. And what you'll often see is where you are testing them, that there'll be changes over time as the suppliers, and I think a lot of these are supposedly coming over from China, as the suppliers supply a particular chemical. That's the one you see appearing in the illicitly manufactured tablets. And there's almost a shift in, I mean, fashion's probably a terrible word to use, but there is almost a shift in the fashions of what you will see changing over time. So whatever I say is in them now might be different in a few months' time. And the other thing that then touches on I think there's a later question that ties into this as well. Roya mentioned the possibility of using drug checking and having amnesty boxes. So probably not enough of the tablets are currently being tested for us to have a really clear picture of what's out there. So there is probably scope for doing more in the way of drug checking and services having ways of testing them. I think it's Dan who's touched on the difficulties in testing for what is an increasingly wide range of different chemicals, and you won't necessarily be able to do that with simple dip tests. But if there are ways of gathering samples and doing better testing so we can get better intelligence, and that's great. We should aim to do that.
Thank you, Steve. Roy or Jeffrey, do you want to come in briefly on any of that? Go for it.
Oh no, you've summed it up brilliantly, Steve. Okay. I don't have anything more to say on that one. Roya.
I think it's just to build on your response to Dan's question around testing the tablet and the substance, but also understanding that even when you know that, the effect it has on an individual is based on lots of other factors. And just being mindful of that translation of, it's great you know the substance and we definitely need to know more of it, but also build on our understanding of how it affects that individual and how we manage that clinically. And I think also the reality is that there are going to be new things that we're going to be always catching up on. And I remember being in clinic, and it was the time when spice, the synthetic cannabinoids came out, seeing somebody completely intoxicated, the tests were all negative, and both of us trying to work out what is it that you've taken that's caused this. And I think there's always going to be that element of unknown that we're going to have to manage in services, but very much would support increasing testing and understanding in the community. So yeah, thank you.
Thank you, Roya. And then Roya, I'll stay with you for this one, if that's okay, and then go to the others. Another of the kind of more technical questions. Sam's asked, I have some specific Lehman questions. See, I don't even know what that means. Is pregabalin a benzodiazepine? Also, are tisalam and clonazepam benzos or analogs? And I suppose I'd take that more broadly. We've talked about analog benzodiazepines. We've talked about kind of novel benzodiazepines. We've talked about fake benzodiazepines. And we've touched on it in the presentations. But Roya, do you want to kick us off with that? And then I'll go to the others, kind of breaking down these categories a little bit.
Oh, I'll have a go. I think if I was a pharmacist, I'd be probably better placed. However, in essence, no, pregabalin isn't classed as a benzodiazepine. It's got its own classification group. But what you heard in my presentation is recognizing that these different groups of drugs can act on the same types of receptors. And so if you were going to categorize substances, you can use the chemistry of it, what it looks like. You can then categorize where it acts, so the benzodiazepine group. But there's also something for us to consider, especially with these new ones, is the effect it has. And sometimes you can group things together based on their effect. And the challenge we've got at the moment is recognizing the overlap of that. So that is a real diffuse start to saying, definitely I can answer the first bit, and also recognize that the newer ones, we're getting to understand where they affect in the brain in order to group them. Okay. That's a good start.
Thank you. And others like to come in and build on that start?
Yeah, tisalam, yes, is an analog. Clonazepam, I think you mean, isn't. That is a benzo. And just be careful of clonazepam, very potent, short acting. And I've had GPs horrified that the fact that 6 milligrams of clonazepam is a huge amount of diazepam equivalence. We're talking 100 milligrams-ish in that territory. So it's very easy to be misguided clinically by the low doses with many of these. So just be really careful. Low dose just means potent.
Thank you.
Shall
Steve?
Yeah, I mean, just you talked about a number of different categories, and I guess what I would say is that some of that is of deep interest to the geeks amongst us. But to some extent, it doesn't matter if it's a benzodiazepine or an analog, or it's novel, or it's fake. As Roy said, you're looking at the effect on the individual and working that out. Certainly, you mentioned the fake ones. I mean, basically, that just means something that's designed to look like an existing medicine. I mean, one of the things that has struck me as interesting is if you look at most ecstasy tablets will be, because an MDMA has never been used as a medicine, they'll be stamped in ways that don't try to mimic a medicine. But most of the street benzos seem to be stamped or marked up in some way to try and vaguely mimic an existing medicine. But they're often so badly done, I don't quite understand the point. But so we are seeing a lot of them marked, like was it Dan 5620 on some of the 2021s. MSJ, I think it is on an awful lot of them. But as I say, I don't quite understand why they are mimicking medicines when they so clearly aren't.
Okay, thank you, Steve. And then Roya, just coming back quickly to you, I think you mentioned in your presentation about using flumazenil, either intramuscularly or nasally, and there's been a comment about that being a sort of good innovation. So do you want to just touch on that briefly?
Yeah, so for clarity, currently flumazenil is only used intravenously within hospital environments. It is not a formulation that can be used nasally or IM. So that's what we're dealing with at the moment. And I did read, there was a really interesting research, I think it was based in the emergency department in France, around retrospectively looking at the use of it and the validity of it in the emergency department room. And they were questioning whether how helpful it was. So I'm kind of cautious to say we need to understand a little bit more about the use of flumazenil as a reversal agent in our hospital environment, and then to, as naloxone has been, take a look at whether therefore it's viable to be changed in a formulation to be easily used in the community. There's a lot more work to be done there, but I know that lots of others have scratched their heads and go, can we have a look at that? And it'd be interesting to explore that further. So hopefully that it just seconds what you're saying, Lisa. It's a good possibility, but there's a bit more information to be gathered to consider that as a viable option.
Thank you, Roya. Jeffrey, we're going to come over to you with the next one. Is the shift towards street benzos a result of changing prescribing patterns?
That's a very good question because we don't know the answers. Although I do think that street benzo use is reducing in some parts of the country as we're educating about the dangers of prescribing. And that's always something I ask patients is, where are you getting these? And invariably the answer nowadays compared to 10 years ago is the internet. And I'm reassured by that. Because what I don't want to hear is, oh yeah, I'm buying it on the street for 50p or £1 for a diazepam tablet. So I think it's the internet and how readily available medications are to purchase without the checks and balances. That's what I think the answer is right now. I think I would have answered yes 10 years ago to your question, but I'm now much more hesitant.
Okay, thank you, Jeffrey. Anyone else want to come in briefly on that one?
I don't think I'll be brief about it, Oliver. I think it's interesting when you look at the history of prescribed medication and how, let's say in benzodiazepines, how they were promoted within certain communities. And I think it is a good thing for us to think about both the pharmaceutical and the clinicians who prescribes attitudes to certain medications and how that changes historically. I could talk about that for a long time because I was fascinated. There was a exhibition I saw that the Royal College of General Practitioners. It was an advert for heroin, because that was a new drug. It was going to be fantastic for pain relief. It wasn't going to be addictive. And look what we found out. And I know that when pregabalin came out, we were hopeful for the use of that for anxiety and nerve pain. And then look what we understood about it. So I think there is a lot of learning for us to take. And I'll probably stop there. Thank you.
Okay, thank you. I'm just going to read a comment actually that someone's put, because it feels like a relevant one to come in here. So John said, in terms of kind of motivations for use and routes of getting hold of benzos, when I speak to lots of people who use drugs, if money is tight, then benzos are a go-to, with the price of tablets being between 50p to £1. Lots of people do not worry about what's in them compared to what feelings they get from them. So I think that's a nice kind of sort of short observation that's just cutting to the heart of some of this stuff, isn't it? Okay, we are going to move. So I wanted to go back to this question of maintenance prescribing, or maybe that's a kind of an old-fashioned phrase to use for it, but a kind of essentially a harm reduction approach to supporting people who are using street drugs, street benzos. And everyone's kind of touched on it. It's obviously one of the key issues in this space, which exists at the sort of meeting point of the formal evidence base, lived experience and what people are telling us, and we do need to listen. The expectation that the evidence base does inform the guidance, but as we've said, the guidance are guidelines, not tramlines. We shouldn't be stuck between them. And we understand there is the sort of 10 or 20% or whatever it was cases where actually as skilled practitioners, you guys are actually making these decisions in partnership with the people getting the support. But it's obviously a really tricky issue. So I just wanted to kind of circle back to that. And someone's posed it in these terms. In general, what is more problematic for society: long-term maintenance benzo prescribing or long-term use of street benzos? Is there a case for setting policy on the basis of the lesser of two evils, i.e. they come in from a harm reduction stance on that? I think is my take from that. So Steve, I'm going to come to you first, if that's okay, and then I'm sure the other two will want to come in as well.
I mean, the short answer is probably yes, that you have to take context into account in setting the policy and then the guidelines. And I think the guidelines already allow for variation according to the context. I think I mentioned some of that at the beginning, that the guidelines would support probably more prescribing of benzos in the context of so much use, so much of availability and then so much use. of street benzos. I noticed there's a kind of a related question in the thread about the geographical differences in benzo use, and therefore then geographical differences potentially in treatment. And again, I think that's one of the context things. You're not just looking at the individual in front of you, although that's definitely the most important thing for the clinicians, but the context can be the geographical setting as well. So in some parts of the country, benzo use is much more widespread, it's much more of a problem, and you might be more willing to consider long-term prescribing if it's a way of battling that particular local context. In an area where it isn't such a big problem, maybe you'd be more inclined to look at the risk-benefit analysis and think, no, I'm going to do my best to maybe prescribe short-term, but then get someone off as quickly as possible.
Okay. Thanks, Steve. So you feel like the current setup is giving local areas enough kind of freedom and autonomy within the guidance to actually kind of, exert that expert view to obviously flex it according to need and so on.
I think so. And I mean, the other thing is just thinking about the word maintenance. It's dangerous, basically. It's politically dangerous, and it's possibly clinically dangerous. So what you should be looking at doing is as Jeffrey and Roya both said, is just looking at prescribing the lowest necessary dose for the shortest possible time. And for some people, that might be quite a high dose for quite a long time, but that isn't necessarily maintenance.
Absolutely. Thank you. Jeffrey, do you want to come in here? You touched on it.
Yeah, I would agree with that. And in terms of harm minimization philosophy, that hits the nail on the head. If somebody is requiring long-term maintenance, and the reason why they require that is because if you start to detox, you will set them up to fail. And all I say is that you keep this issue live in the care plan. Detox is the evidence base that we have, but we know that won't suit everyone, and you should keep addressing this. So what we don't want to do is just leave this be, and also not be ambitious for our clients, because I must say I've been sometimes surprised where we have been very proactive and really encouraged a particular client to detox. They've managed to do this despite resisting this vehemently for years and years. And if there's a lot of complexity and you really compel somebody to detox, what you'll find is that they will simply start using illicitly, or use more heroin, or use more alcohol, etc., etc. So I think there is a case for long-term prescribing on a case-by-case basis. Absolutely.
Thank you, Jeffrey. Roya?
Yeah, I think both my colleagues have probably covered the essential points that I'd like to say. I think anything enforced, as I said in my presentation, I don't like to be forced to do anything. Nobody else does. And I think there's something to recognize about making that shared decision. The guidance provides flexibility for individual clinical assessment and the challenges around decisional balance. And I think we need to acknowledge that consistency in that clinical decision may not always be as we would like to see it. So not only within maybe our own services, but nationally, but take into account, as Steve astutely has put, some of the factors that affect that. And maybe by having greater dialogue, shared case studies, more lived experience stories, we can build on that and we can improve that maybe. But the research on different cohorts of individuals, because I can see on the questions there's talks about the aging, an older population, and there are different reasons and different themes of benzo use, and I think we need to understand individually those a bit more, and that might help our clinical practice.
Okay, thank you. Now there's a couple of comments which I guess are looking back at the reasons of how we've got to this position, and one person said, I find this very strange given known withdrawal and potency, etc. Seems like the level of care in prescribing benzos seems to be lacking in comparison to some other medications. Just an observation. And then Chris has said, barbiturates, then benzos, then pregabalin, now novel benzos, as benzo prescribing drops off a cliff. Have prescribers forgotten their part in creating the mess we're in? 30 milligrams of diazepam a day in substitution won't touch the sides of a severe dependence. So, a bit of challenge there, but they're legitimate questions, and it is also illustrative sometimes to look back to see where we've come from, to see where we've got to the current position without being held hostage by the past, of course. So, have we done enough? I mean, the big we, the whole system, clearly something's not working because more and more people are dying, and we can't think of a more acute harm than the people we serve dying. So it's right, I think, that we sort of take this question on. Any volunteers for starting?
Yeah,
Jeffrey?
I was going to say, so I do go up to 40, but as you're saying, Chris, I would try and aim for lowest dose possible, and often that is 30 milligrams a day. We can't verify how much somebody is using, unfortunately, and people will often say that they're using 100 milligrams, 200 milligrams equivalents, but what reassures me is that the complicated withdrawals shouldn't develop if we're prescribing a fairly high dose, as in 30 or 40 milligrams of diazepam. We can reassure this client that, well, yes, it might be a lot less than what you're taking, but it's a safe dose, and you won't get the withdrawals that will be potentially life-threatening. And I don't know how else to do this safely. And that is really the difficult one. But I know that it won't necessarily hit side, because it's a lower dose compared to what they say they are using.
Thank you. Steve, Roya?
I don't think I could add much to to Jeffrey's. I mean, it's interesting some of the points Chris raises, because it sounds like he's talking about past prescribing patterns have created some of the problems, but then considering whether or not prescribing patterns then solve the problems, but they do then risk just creating further problems of their own. It's one of these. It's not simple, is it?
Definitely not. Roya, did you want to come in on that?
I think it can be a real challenge when you're presenting with somebody who is dependent on significantly high doses of benzos, and supporting the individual, if they are motivated and wish to do a part self-reduction of what they're taking out in the community, whilst being aware of the limitations and the rightful limitations of what you can prescribe as a clinician. But at the same time, recognize that there are other interventions, psychological and psychosocial interventions, that can support somebody with respect to the reasons why they're taking the benzodiazepine in the first place and the withdrawal. So it's not necessarily replacing like with medication with medication. There are other things that can be that are important to be addressed, and that might be supportive.
Thank you. I'm just going to read out a comment because I think it's interesting. An anonymous attendee has said, I work at a drug service in East London. There are a few maintenance script legacy clients, as we call them. We are not commissioned to generate benzo scripts, yet there are a group of clients who've been very reluctant to come off the medication after many years. Lots of resistance, massively influenced by the language, I can imagine. I presume that means sort of language in which these issues are discussed and talked about. Okay, thank you. Jeffrey, I've got another one for you. I think you signified you were interested in taking this one on. So Michael's asked, it can take ages to do slow benzo reduction. So is there an argument for long-term tailored prescribing? You might feel you've already covered it, but go for it.
I think we did cover that, yeah, in the past. There was another question very similar. And I think yes is the short and long answer.
Okay. Taruna has asked, I've worked with service users who've reported using diazepam and pain relief regularly to address pain. Have others had this experience?
If I can
go for it.
Yeah, pick that up. It builds on, I think somebody else was anonymous was talking about back pain. So muscle spasm can cause a lot of pain, and benzodiazepine, short-term acute, can be used to manage that. I know if I've done a home visit on a young person who can't stand because of muscular spasm, once you've ruled everything out, short-term, it can be used. But long-term, there is that risk of, we talked about dependence and tolerance. And I would say pain management in general in that cohort of individuals is quite complex and requires an individualized breakdown of why, what. So there's no quick answer for it other than to say, yep, recognize the use of benzos in that cohort as well as opiates. And it takes that individualized unpicking to work out the best management plan.
Mm-hmm. Thank you. Anyone else want to come in on that one? No? Okay. Jeffrey, I've got one here that you said you were interested in. So Michael has asked, should Z drug users be converted to diazepam for slow reduction?
So yes, generally, although I have reduced, because obviously you do have that formulation where you can reduce really gradually using zopiclone, for example. But often the problem is that it hasn't worked, and that's why we're seeing this person in the first place. So yes, you can give that a try, particularly in primary care. But I think in the addiction setting, it normally will have failed, and that's why we're dealing with that. And we would convert to diazepam equivalents because it does allow us to do a very gradual reduction. And remember, the diazepam oral solution, 2 milligrams and 5 mils, does allow a really graded reduction. And I think somebody did mention this somewhere, and I think slow is, we're really happy when people detox, and I would do it very gradually. There's no reason to rush this if it's a very long-standing prescription, which is often the case.
Thank you, Jeffrey. There's been a couple of questions. It's one of the themes in my mind actually about segmenting the people that we're supporting here into different categories. Now, categories and typologies are never perfect because they're still categories, and we're all complex human beings at the end of the day, but they do give us a greater degree of resolution than just saying here's a giant category of people called people who are using benzos. It does help to break down, obviously. So there's a question here about different client types, i.e. opioid users, I think. So older long-term clients with no previous drug use. Is there an argument for separate services? I mean, I'd just broaden that out a bit, I think, and maybe Steve, I'll come to you for sort of data and policy perspective and then go to Roya and Jeffrey. But do we know enough about the different categories of people who are using benzos? Is the data good enough? Are the stories good enough about our understanding of why people are using these drugs? And then Jeffrey and Roy, if you can think about, have we appropriately kind of segmented the clinical and therapeutic response to those different groups of people? I'll come to you. Thank you.
Thanks. Yeah, it's an interesting question. I was thinking about it a bit earlier when people were talking. So we've mostly been talking about, I guess, the kind of opioid and poly drug users and what they get from benzos. But when we were talking about Xanax earlier, that's particularly associated with young people, just using it recreationally, for want of a better word, and then maybe getting into problems with that, particularly if it's not alprazolam at all, or they're using it long term, becoming dependent on it. And then the other population we've just kind of touched on only, that PHE talked about in its prescribed medicines review, is the people who've basically been introduced to their benzodiazepine dependence by very long-term prescribing that wasn't necessarily appropriate. And the sort of the services that you might commission for each of those and the ways in which clinicians might treat them will obviously be quite different. And whether or not commissioners see them as something that they should be commissioning services for at all is a bit of a problem and varies massively across the country. So, I mean, what we said previously in guidance is that you would expect a local area to have some sort of provision for all those populations, and particularly for the ones that are created by prescribing. Primary care should generally be the first port of call. To some extent that they cause the problem, they should be picking up the problem, but they should be competent to pick up the problem anyway. Then you've got specialist drug services who can provide support to primary care to enable them to deal with some of the thornier issues, the longer term, more complex cases. And then where they're commissioned to do so, specialist drug services should be able to treat the really complex and severe cases, and they should be able and willing to step in. But that does depend on them being commissioned to do so, which in an awful lot of areas they aren't. And when we had a kind of retrenchment of services on the back of shrinking funding, that wasn't at all surprising. You could see that services going back to a kind of core of the most problematic, the most criminal, if you like, was where you'd expect local authority commissioning to be from. But as we're expanding the funding, I think I said at the top, I would hope that services are going to be better able to think about dealing with a broader range of patients again.
Thank you, Steve. And then to come to the others, I'm just going to slip in another question because it's relevant here. But Kirsty said, how do you balance the treatment needs when the people with dependency are children? I've seen a significant increase in dependency in young males, 15 to 18. It's very difficult to advise a child to continue using illicitly and reduce. However, being an adolescent just increases all risks, including poly, substance use, impulsivity, etc. So, you know, chuck that curveball at you, but weave that into your answer as well, if that's okay. Thank you. Jeffrey.
Yeah, I noticed that as well from Kirsty, and it's really interesting that, and I don't see why you would separate an older client group necessarily, except we would focus on the particular needs of this patient. And I must say, there have been certain cases where I have said, look, this person is 88 years old and, you know, they're on lorazepam 2 milligrams for 50 years. Do we really want to address this? In fact, I had a case, somebody on chloral hydrate, and it just seemed like it just was not the wisest thing to do. So I don't really see the advantage of separating out. Obviously, with young people, it is different. And, you know, we would proactively treat and be very cautious about their career in addiction. And often the argument is, well, we need to be really cautious about initiating prescribing because otherwise they will become career patients. But actually what Kirsty's alluding to, and I would agree with, often they've developed adult habits by the time you've seen them. And this person that you're mentioning, Kirsty, is quite complex. And if there is a benzodependence, we need to address that as we would in adults, but also address all the comorbidity that comes with it, as you're alluding to. So yes, it's risky, but this is really our job as specialist addiction services, is to manage this risk.
Thanks, Jeffrey. Roya?
I suppose I'd take like the whole system approach and sort of second the value of our GP colleagues in addressing not just benzodiazepine, but drug, including alcohol use. And I think we could probably work together under the new umbrellas of ICSs in looking at where treatment can be offered at the right place for the person. Yeah, second everything that Jeff said about young people. It's challenging, and I just note that John's put a link around a research project in exploring the use of benzos in the young. So if you know, take a look at the questions there. So I think there's a lot more information and research needed there, and looking at our different colleagues across health and social care that can address this. The older age group has come up with alcohol as well, and I think there's a physiological difference sometimes with the older age group and also younger. So we just need to upskill the workforce around the different management types and direct people to the most appropriate service and the one they want to go to. That's important. No wrong door, and yeah, exploring more community services where people travel less. Thank you.
Thanks, Roya. I'm just going to read a couple of the comments as well to get other people's voices into this conversation. So Brian has said, as an ex-problem opiate and benzo user, I found it counterproductive being prescribed benzos for detox or harm reduction. I found it prolonged my addictive behavior. So that's an interesting perspective in this. And then Harry has said, there can be a limitation of skilled psychosocial intervention delivery to support the reality of a patient doing a benzo reduction. I think that's such an important point, which I guess Steve touched on in terms of like the effects of all those cuts of the past decade. And hopefully we're at a point of more positivity with the funding coming in for that capacity to be built back into the system. And then an anonymous user said, I know someone who is prescribed clonazepam in the short term for bipolar disorder alongside olanzapine. Working in drug treatment, I was shocked how quickly this was withdrawn from their treatment and replaced with an SSRI instead. Welcome to comment on that, yeah, Jeffrey?
Yeah, I mean, I agree. And I think there's probably a misunderstanding about how potent clonazepam is. You're absolutely right. And I think in the acute setting, absolutely, but acute must mean acute. And I certainly have picked up a number of cases from secondary care mental health services where somebody has developed dependence because clonazepam was started and not addressed. And I would convert to diazepam in that case. Absolutely.
Thanks, Jeffrey. Steve, so we're nearly out of time, but Steve, I'm going to go on, Jeffrey.
Oh, no, I'm just going to say there's a question that's a little bit aligned to this. It's about 65 milligrams of diazepam. And I just wanted to say anecdotally that I've learnt my lesson with that one as well, because you see, I had a couple of patients who were prescribed clonazepam and diazepam, and it was really a struggle to get them to address this and go on to diazepam only. And the only way I could do this in the day was really to offer this patient a higher dose of diazepam. She was really unhappy. She was almost spitting blood at me. And I did initiate 60 milligrams of diazepam, and she was still unhappy. And it was a huge struggle to get that dose down. So my inclination now is max out at 40 milligrams, reassuring, saying, you know, you will not get significant withdrawals. And obviously, if you do get anxious, we can prescribe an antidepressant. We can think about psychological treatment. There are other things, and including promethazine as a hypnotic. I know some patients won't be very interested in that, but experience has taught me not to be tempted by that, although I know it is really difficult in the situation with somebody in front of you.
Thanks, Jeffrey. Steve, I'm going to come to you with a quick one here. Has there been many cases of people knowingly buying analogs online in preference to other benzos, or are all the cases mentioned of analogs people who've bought them with the intention of getting diazepam, Xanax, etc.?
To be honest, I don't know. I mean, I don't know what people's intentions are when they go online to buy things. I imagine there's a bit of both, and and quite what the balance is between them. Couldn't tell you.
Yeah, fair comment. Thank you. Where are we at with time? We're sort of pretty close to 4:30, aren't we? So before I close up, folks, I just wanted to give each of you three a chance just to offer any final reflections, sort of 60 seconds each, just to round things off, and then we'll have come kind of full circle and we'll close up. Steve, as you're on, do you want to?
Yeah, I guess I just wanted to say that, so I'd see this as being the beginning of a process to some extent. So I think we're already recognizing that something more needs to be done to look at the widespread use of benzos and how they're treated. And certainly OHID will be doing more on this over the coming months and years.
Excellent. Thank you. Roya?
Yeah, value the conversation, and just picking up a point that Anthony's made about understanding the underlying reasons why somebody will knowingly use benzo, and understanding that story and traumatic experiences. Very important to consider when we're making a clinical plan. So I think that's a good one to end, just to recognise lived experience. Thank you.
Thank you, Roya. Jeffrey?
Oh, I mean, this is a great opportunity to come together and start the conversation. We don't have all the answers. We're all grappling with this, but at least we are talking about this, because I think for many years we weren't actually able to have this conversation. Nobody wanted to listen. You know, it's not our business. This belongs in primary care. GPs were saying, but actually these patients are really complex. They're risky. There's comorbidity. You know, we need support with this. And I think, you know, this problem is clearly having huge ramifications. If you look at the drug-related death data, that's just one of the cases in point. So absolutely. Thanks so much for this opportunity, for all of you for joining.
That's fantastic. Thank you, Jeffrey. And I guess to just round off, we've got Yeah, so okay, Hayley, we've just got 2 minutes. So Hayley, if you can keep it brief, you're welcome to come in here and we'll have a question from the floor, as it were. Oh, you've put your hand down. Okay, no worries. So just to round that off, I'd say in conclusion, firstly, big thank you to everyone to be part of this. It feels like a really open topic, if you know what I mean, by which it's just the building blocks are kind of all there, but we haven't worked out how to put them together in the right order or the right pattern. Everyone's committed, everyone's interested, everyone's seeing it from their different perspective within the system, but we haven't quite got there. And to be honest, it's probably an evolving complex situation. We'll never feel like we've got there, job done, because that's not how evolving complex challenges work. We've got to keep chipping away and generating new evidence and new connection and listening to people. So I think this is a kind of feels like a bit of an ongoing sort of work stream almost, doesn't it? So Steve, really pleased to hear about OHID's kind of focus and commitment on that. And I'm sure we'd all kind of mirror it as well. It does feel hopefully like the start of something, and we can continue these conversations over the coming months, years. Definitely feels like a topic which kind of recovery and harm reduction approaches are interwoven, both completely essential. So my characterization of this issue is completely kind of pluralistic and open. We need all of the approaches. We need yes and that and that and that. And we need to listen to people who are in recovery and also in treatment and also out of treatment, actually, although it's sometimes harder to do, but there is a good aim. I think we've got to be humble about the fact the system isn't working as well as it could do and should do at the moment. And to end on an up note, we do have this wider kind of political policy environment where we at long last have had political attention on our system, the money flowing in. I know it's still really hard. I know that it's flowing into quite a fragmented system, and there's loads of challenges around recruitment and skills and kind of training people and stuff like that, and lots of other things as well. But finally we've got some of the big picture factors kind of pointing in the right direction, if you like. So it is a really good time for us as a system to come together for this conversation. Collective Voice will kind of collate this in terms of the video, as I said, the PowerPoints, and also there's a couple of links to papers and stuff like that in the chat. So we'll take those. If anyone else wants to tweet us or email us with a really good resource on this topic, please do. And I mean attendees as well as our panel, we will put that on there as a repository of kind of informal information and guidance. So yeah, thank you again. Let's keep this going. And I hope you found it a informative and thought-provoking 90 minutes. Thank you.
Thank you all.
Bye.